there, I'm Ansara Piebenga, and my younger daughter had a combined kidney and liver transplant 16 years ago, and she's now 17 years old, and she's doing great, but she does have hypertension and as a result of her kidney disease. So we're always trying to learn more about how to address her high blood pressure. I'm really excited to introduce you to this next session called Pediatric Hypertension in All Transplant Patients, and we're very lucky to have a true expert on the topic with us here today. Abanti Chaudhuri is a pediatric nephrologist. She's the co-director of the Pediatric Kidney Transplant Program and the director of the Pediatric Hypertension Clinic at Lucile Packard Children's Hospital at Stanford Children's Health. Dr. Chaudhuri, we are so grateful that you're here with us today, and now I will turn it over to you.
Thank you, Ansara. You can hear me okay?
Yes.
Yep. Okay, so while we recognize the National Pediatric Transplant Week this week, I am really honored to have this opportunity to talk about the importance of recognizing and treating hypertension in children who have received solid organ transplantation. Hypertension is really now one of the most common health concerns in all children. Based on the data from the National Health and Nutrition Examination Survey, the NHANES data, the prevalence of elevated blood pressure, which includes both pre-hypertension and hypertension, is continuing to rise from 1988 to 2008 to now, in all age groups, in both boys and girls, basically in all children. And much of this is driven by the increasing body mass index, increasing waist circumference and sodium intake. However, children with who have received solid organ transplantation, hypertension is more common. And because they have these additional risk factors apart from being children, which make them especially prone to developing hypertension. And that includes several donor and recipient factors, and some underlying disease in case of kidney transplants and how the kidney is functioning, etc. Here are some risk factors that I have listed based on several pediatric studies, which vary from the population that is studied. However, one thing is pretty constant, that they all receive immunosuppression, which of course they absolutely need. However, some immunosuppression is known to increase the risk of hypertension. And for example, steroid treatment is associated with sustained hypertension and worsening blood pressure status. But that depends on the dose and the person, and also high calcineurin inhibitor levels, trough levels. Cyclosporin more than tacrolimus are associated with hypertension. So most of the literature on hypertension and solid organ transplantation is focused on kidney transplant recipients because this is the subset of children who tend to have the most hypertension. And the largest study on this subject is from Europe, and they gathered data from this registry where they analyzed 336 pediatric kidney transplant recipients and found that, and they basically followed them up from transplant to discharge to 3 years post-transplant, and found that a significant 84% at the time of discharge to 77% at 3-year post-transplant actually have hypertension. And a lot of them in the dark black bars are uncontrolled hypertension. High hypertension prevalence is also seen in other organ transplants, such as this study of 188 heart transplant recipients who had and hypertension was defined in this study as antihypertensive medication use, and they found that 24%, about 25% of kids received IV antihypertensive medication right after transplant in the ICU, and about 30% continued to require oral antihypertensive agent at the time of discharge and even 1 year after follow-up. And even though data is limited, there are some pediatric studies, and the general impression is that children who have received a transplant have a much higher prevalence of hypertension, irrespective of the type of transplant, when compared to age and sex match control. And this is a German study which showed different pediatric transplantation. Kidney transplantation obviously leads the way because of various risk factors, but it is definitely more common in solid organ transplantation. As in other populations with pediatric hypertension, there is really not much long-term data in pediatrics, even in solid organ transplantation. So that is no difference. The data that shows what does this hypertension do long-term. But there are some short-term data in the literature. Also we extrapolate from the adult literature and know that hypertension is associated with subclinical cardiovascular end organ damage. And in this study, where 221 pediatric kidney transplant recipients, the kids with hypertension, sustained hypertension, had a higher prevalence of, definitely had association with left ventricular mass index and left ventricular hypertrophy prevalence, which is obviously a cardiovascular risk long term. Similarly, also this group of another group of pediatric kidney transplant recipients found to have increased arterial stiffness that increases after transplantation as you go along transplantation, and the increase is associated with higher blood pressure values. So higher the blood pressure value, increased arterial stiffness. And in kidney transplant recipients, in addition, uncontrolled systolic and diastolic hypertension is thought to lead to overall worse allograft survival. And I know this graph is not very clear. The top line is actually the indexed blood pressure less than 95th centile, which is the good control versus the bad control, and better allograft function with good control. And this and that systolic hypertension is independently associated with allograft function, irrespective of the other factors that also affect allograft function. So while hypertension does not sound like a good thing at all, I want all of us to recognize that it is a modifiable risk factor and that it can be treated for better outcomes. For that reason, it is really important we diagnose and treat hypertension really well. In 2017, the American Academy of Pediatrics, along with American Heart Association, published guidelines and used the adult cutoff values of less than 120/80 to be normal blood pressure for anybody who's more than 13 years of age. For children who are less than 13 years of age, they should have their normal blood pressure as to be less than 90th centile. And the centiles are elaborated in the guidelines. They're from manual blood pressure measurements of children who were sitting and resting for 5 minutes in 50,000 of these kids, and they also had normal weight. Even though there are no specific goals described for children with transplants, these guidelines did recommend that children with solid organ transplants should have their blood pressure measured at all ages. So this is different from the children who do not have a transplant, because the recommendation is for them to have blood pressure measured more than 3 years of age. And the 2017 guidelines also puts out this complicated algorithm as how blood pressure should be measured in clinic. And really, we have to remember that the blood pressures in elaborated in the normative value are all manual blood pressures. And when children come to clinic, they actually have machine blood pressure. So we are not always comparing apples to apples, but the guidelines do say that machine blood pressure or oscillometric blood devices may be used for blood pressure screening, as long as the device is validated and for use in the pediatric age group. And if elevated blood pressure is suspected on the basis of machine blood pressure, then manual blood pressure need to be repeated. What is very important, though, is that the measurements are accurate and we ensure that the child is sitting quietly for 5 minutes with feet on the ground, back resting straight, arm at the level of the heart, and in basically comfortable, hopefully not had caffeine the last 30 minutes, and not talking during the measurement. And the blood pressure is actually measured in the right arm and with the appropriately sized cuff based on the mid-arm circumference, and it should be manual preferably. And we all know that this doesn't always happen in a clinic setting. And so hypertension in children have been under-recognized, under-diagnosed, and children with transplants, without transplants. And this is the IROC Collaborative, Improving Renal Outcomes Collaborative, who collected data over 12 weeks from 17 pediatric kidney transplant centers. They're nephrology centers across the United States, and found that only 11% of the visits had documentation of blood pressure measured appropriately. So this is their pre-intervention period. Till they had a structured quality improvement activity, that's the intervention, where they laid out protocol for educating the clinic staff, assigning the specific team member roles, creating blood pressure tracking tools and alerts, and made sure the elements that are required for accurate blood pressure measurements are documented, which includes the arm circumference measurement, the blood pressure cuff size documented and correct, using the right arm for blood pressure measurement, resting for 5 minutes and averaging the 2 readings. There has to be more than 1 reading. And by this intervention, the accurate blood pressure measurement documentation improved to 78.4%. So we do have work to do in our clinics to make sure blood pressure is accurately measured. So the 2017 clinical guidelines also have give more emphasis to the use of ambulatory blood pressure monitoring for diagnosing and monitoring hypertension. And what it involves is a blood pressure cuff is placed on the child and child goes home. Over 24 hours, blood pressures are measured, and 40 to 50 readings has to be there at least in 24 hours for the study to be successful. The accurate time that the child went to sleep that day needs to be determined, so we know which are awake blood pressures, which are asleep blood pressures. And then we determine the 95th centile, and if the average of the daytime and the nighttime systolic and diastolic blood pressure are above the 95th centile. The 95th centile for this is different from the 2017 clinical practice guidelines, because remember, those are manual blood pressures and resting. These are machine blood pressures and ambulatory, so there's different sets of data. And then we also look at the dipping to make sure the morning blood pressure, when the child went to sleep, there is at least 10% of dipping. And the guidelines for hypertension diagnosis by ABPM was recently published also, using the adult cutoff values for less than 130/80 for awake blood pressures, less than 110/65 for sleep, and overall. Note that these are a little higher than the 2017 guidelines, because those are resting blood pressures and these are ambulatory blood pressures. So there is a little higher. And then for children who are less than 13 years of age, they should also use the centiles, and the average needs to be less than 95th centile to call normal. Ambulatory blood pressure monitoring is more accurate than clinic blood pressures. Blood pressure is a dynamic phenomenon and varies during the day. And one office blood pressure does not determine who's hypertensive, who's not. ABPM can identify white coat hypertension. It avoids unnecessary diagnostic testing or medication use, and it also can be used for monitoring of efficacy and of antihypertensive therapy. But it is not tolerated by all children. It certainly cannot be used less than 5 years of age, because the children are too young to tolerate that, and also there is no normative value to know what it should be. And there is no data, just like the other guidelines, specific for solid organ transplant recipients. ABPM helps us diagnose the masked hypertension and nocturnal hypertension, which you cannot get from a clinic blood pressure or a blood pressure measured anywhere. Now, masked hypertension is diagnosed when the office blood pressure is normal and the ABPM reveals hypertension at home. And that has been shown to be associated with poor cardiovascular outcomes. In this study of 221 kidney transplant recipients, a lot more kids were diagnosed by ABPM as opposed to clinic blood pressures, which means that if you just relied on clinic blood pressure, some would have been missed, and a significant 25% had masked hypertension. Also, the nighttime hypertension for both systolic and diastolic in these orange bars were higher than the daytime blood pressures, and all of these things can be done with ABPM and not clinic blood pressures. Similarly, 34 patients who had pediatric heart transplants also were found to have, a significant proportion of them were found to have isolated nocturnal hypertension and masked hypertension. And also a lot of them were non-dippers, which is a characteristic finding in all solid organ transplant recipients. And some of them are actually reverse dipper. Instead of dipping low, they are actually higher at night when they're compared to children who did not receive a transplant. Similarly, liver transplant patients also benefit from the ABPM. In these 36 patients, only one was detected as to be hypertensive by casual office blood pressure measurement, when 17 patients were found to be, which is 47%, were found to be hypertensive by the ABPM measurements. And as I said, masked hypertension needs to be diagnosed because it is associated with left ventricular hypertrophy. Now, these studies are not transplant population, because this is general pediatric population, and it's kids with CKD, chronic kidney disease. And masked hypertension has been shown to be associated with more LVMI, hence more left ventricular hypertrophy, than kids who are normotensive. Kids who have nocturnal hypertension also have been shown to have higher left ventricular mass index, as in left ventricular hypertrophy. So a kid could have normal blood pressures during the day and have normal high blood pressures at night, and that needs to be identified to be able to treat. Now, while I'm kind of recommending that kids who have solid organ transplantation should have ABPM, preferably annually, but ABPM is not always available everywhere. And so when it is not available, it is okay to have good manual blood pressure readings in the office, done in the correct way with the appropriate size cuff and exactly as we talked about, and achieve a goal. And that also is a reasonable approach. We should never undermine the importance of home blood pressure monitoring, and usually this is a lot of partnership with the family and with the clinic staff to assess what the blood pressure load, what blood pressure burden is for the child. Home blood pressure monitoring is convenient, it's cost effective, it's widely available, can be used over time. Many children feel much more comfortable at home with their parents than at clinic, so there's more chance of getting accurate blood pressures. It is definitely more reliable than casual office blood pressures in predicting end organ disease. However, it cannot be the only thing that we can base our diagnosis on. It is a useful adjunct to monitor therapy and everything, because there is a risk of inaccurate diagnosis. It is important to make sure we tell the families what size cuff to use, to train them, whether it's machine or manual blood pressures, practice them in clinic, evaluate in office, correlate the machine in clinic. It's a process, but it's important to get it right. Again, hypertension is a modifiable risk factor. If we control the blood pressure, the risks do get better. It doesn't remain a risk anymore. So in this 142 children post-kidney transplant patients, pediatric patients, who had left ventricular hypertrophy near the time of the transplant over time actually got better, and they had controlled hypertension. The children who did not have controlled hypertension, their left ventricular mass index continued to increase over time. Now, but what is control? We talked about the guidelines, but they are for blanket all children. There is no specific goal for solid organ transplantation. And there has been talk about strict control of blood pressure. And those who are nephrologists, we know about this ESCAPE trial where they studied children with chronic kidney disease, and they found that if the blood pressure was controlled strictly, where the target blood pressure was in the lower range of normal, there was substantial benefit with kidney function. So the lower was better. This approach was studied in a small group of pediatric renal kidney transplant patients, and they did not find that their allograft function actually was any different when they compared with the standard group, standard blood pressure group versus the intensified blood pressure group. However, this has to be interpreted with caution because this is a small study, and this doesn't mean that it doesn't help. So good control of blood pressure is always important. And there are a variety of agents. There is no guideline to which agent to use first. The 2021 KDIGO guidelines, these are for adult kidney transplant recipients. They do say the calcium channel blocker and ARB as a first-line antihypertensive agent. And we do see that in our clinical practice. This is again from that European Registry of Kidney Transplant Kids. And it was seen that this is calcium channel blocker, the blue, the orange is the ARB. And at the time of discharge, more people were on calcium channel blocker and less on ARB, which is understandable. We like to use ARB a little later. And then this is at the time, 3 years post-transplant, still ARB and calcium channel blocker being the agents. But then oftentimes we will need more than one agent, to more than two agents, but the main point is to get the hypertension under control. And then
sorry to interrupt you, but we have about 3 minutes left. I'm just giving you
okay.
Okay.
This is my last but one, but this is just like the timing of the antihypertensive medication is important. There is some talk about giving it in the night. That really helps in lowering the blood pressure. It's seen in pediatric population, see lower blood pressures and lower better dipper status than control. And this is just my conclusion, but I just want to stress on this, that hypertension is a modifiable risk factor, and I'm done. Thank you.
Thank you so much. That's really great. We really appreciate it. I think there's time for one quick question, okay? We have one. Why is younger age at transplant associated with increased risk of hypertension? Is it simply because of longer exposure to immunosuppression?
Yeah, that's a really good question. It is actually, one study showed younger kids are at more risk. And then there is another study that said that the younger kids are on lesser antihypertensive medication. But I think it's longer on immunosuppression for sure. It could be one of the reasons. And then there is, there is a study for kids with heart transplant showed the higher donor to recipient weight ratio, and that also is a predicting factor. So the younger you are, the ratio would be higher. So
okay, thank you. And we do have one more quick one here. My son had hypertension after his liver transplant, so was taking amlodipine, but went off of Tacro and amlodipine for PTLD for 2 months and is now back on. So we have a machine to check BP at home, but he almost never sits still because he's moving and hates the cuff. So we can't tell if the reading is correct. We've taken several in a row, but he moves so much so often that the reading almost always fails. How can we get better readings?
Yeah, this is, I am guessing your son is young. How old?
I don't know. I don't know from the
yeah,
question.
so this is, sorry?
Probably young, it sounds like.
Yeah, definitely young, because If you're more than 5, you can do a ABPM and, just get it done that way. If you're less than 5, this is a problem.
Sorry. They just said he's 14 months old. So
Yeah,
very young.
this is a problem, and I do see a lot of liver transplant kids, and it's just a process, and we get better. We bring them in clinic. I try, parents try, and we get some good readings. It is. I don't have a way to tell you how to get this right, but we just have to keep trying. Yeah, it's tough. The good thing about a lot of the liver transplant recipients, I see that they get grow over their hypertension and get better because with the prograf or other things get lower over time, but hopefully.
Thank you so much. We really, really appreciate you. And thank you so much for talking about this topic. And I wish we had more time because we have more questions. So we really appreciate your time, and
Thank you.
thank you everyone for tuning in. And thank you so much, Dr. Chaudhuri.
Thank you. Bye.
Bye.